Premature ovarian insufficiency also has other names, yeah. For example, they are previously called as premature ovarian failure, premature menopause, hypergonadotrophic amenorrhea, climacteric precox. But now we have changed to premature ovarian insufficiency. Basically, because if you put them menopause, is it like you have no chance at all? But in premature ovarian insufficiency, occasionally you see patients, they have come back, they have return of fertility. You still see patients who we diagnose as premature ovarian failure. Occasionally, they have resumption of normal menses and they can able to get pregnant. So based on that, the terminology now, which universally is accepted, is to use premature ovarian insufficiency. So basically, this is a hypergonadotrophic hypergonadism where it stems from when the ovary is devoid of any more follicle size. Okay, ovary is devoid of follicle size, and as a result of that, there will be a lot of secretion of FSH and LH from the pituitary. So that's why it is called as hypergonadotrophic hypergonadism. Okay. If you look at this graph, the expected age of menopause for a Malaysian lady is about 51.2 years old. Yeah, so this is the average age of menopausal. If a lady had a menopause between 40 to 45, she is termed as early menopause. But however, if she has a menopausal occurring below than 40, she is termed as premature ovarian insufficiency. Okay? So basically, when we say premature ovarian insufficiency, it's a clinical syndrome defined by loss of ovarian activity before the age of 40. It is characterized by menstrual disturbance, either amenorrhea or oligoamenorrhea, with evidence of raised gonadotrophin and low estradiol. So based on this, the ASHRAE GDG recommends for you to diagnose the patient as having premature ovarian insufficiency, you must have an oligomenorrhea or amenorrhea for at least 4 months. And when you do the measurement of the FSH, tiga mic, okay. When you do the measurement, okay. When you do the measurement of FSH, it is more than 25 international unit per liter, and you have to take 2 samples. That means on 2 occasions, which both samples are taken 4 weeks apart. Why we take 25 IU and not usually 40 IU? Because it is noted that if you take 30 IU and you go and do ovarian sampling, probably the chance of finding follicles in the sample is probably, in the histological sample, probably you cannot find any more ovarian follicles. So based on that, 25 IU is being taken. Okay. So what is the incidence like? Yeah, it's not common. If you go by the age, it's 1 in 1%. 1% of women under the age, at the time of the age of 40. But if you look at among the 30s, 30 years old is about 1 in 1,000, and among in 20 years old is about 1 in 10,000. And as what Dr. Noashikin illustrated the case yesterday, we can also see patients who are premature ovarian insufficiency presenting to us as primary ovarian failure. Yeah, presenting with primary amenorrhea. That means they don't have menses, and when you examine, they are actually already gone into premature ovarian insufficiency, and that is quite high because the prevalence is about 10 to 28%. Now, what are the causes of premature ovarian insufficiency? You can divide it into iatrogenic or spontaneous. Among the 2 commonest causes of iatrogenic premature ovarian insufficiency is because of the gynecological surgery that we do. We remove the ovary because of the disease, for example, endometriosis and so on, or because of treatment for malignant and chronic disease requiring chemotherapy, which subsequently cause the detrimental effect on the ovarian follicle. The spontaneous causes of premature ovarian insufficiency can be divided into several etiological background. For example, you can have the genetic disorders, the autoimmune disease, The family recurrence about 20%. But in majority of cases of premature ovarian insufficiency, we estimate about 60% of the time we do not know what is the causative factors for the premature ovarian insufficiency. Now, what do we do when a patient presenting to us? We examine them, we did an investigation, and we say that they fit to be diagnosed as premature ovarian insufficiency. The next step is to find what are the cause of the premature ovarian insufficiency. So basically, when a patient comes, regardless of what age, not only primary amenorrhea, even if they come at 30 years old with secondary amenorrhea, chromosomal analysis is a must. Because you still can have patients presenting with secondary amenorrhea, yet they have some chromosomal anomalies. So chromosomal analysis is a must that you do in a patient who has premature ovarian insufficiency. The next is to test for fragile X, permutation testing. So what I do is actually when I send for chromosomal analysis, I write an instruction there. Please also analyze for fragile X syndrome. So that the geneticists or those who run the test will actually look for evidence of chromosome breakup at the X chromosome. Autoimmune, ovarian autoantibodies, thyroid autoantibodies, adrenocorticoid autoantibodies. So it can cause, the autoantibodies can actually cause destruction of the follicles of the ovary. Now, the problem with us in Ministry of Health, we cannot send ovarian autoantibodies. No lab can do that. Yeah, but we can send it privately, but it's expensive. Yeah, ovarian autoantibodies, adrenocortical autoantibodies is very expensive. Yeah, so what I usually do is to get history from the patient, whether to see she has risk factor for autoimmune, and the next we can send, that we can easily send from our lab, is actually to do the thyroid autoantibodies. And infection, yeah. In male, we always ask male with azoospermia, ada tak pernah dapat bengkak cantik dulu? Because mumps can cause mumps, what is that? Mumps infection that destroy the germ cells of the testes and causes azoospermia. The same goes with female. Yeah, mumps infection in female can also cause mumps oophorytis, resulting in premature ovarian insufficiency. So like I said just now, in a significant number of women, about 60% of them, no cause can actually be identified, and we term this patient as idiopathic premature ovarian insufficiency. Now, the chromosome testing, we will usually find abnormalities more so in primary amenorrhea, okay, and 10 to 12% of women who have chromosomal anomalies, majority are X chromosomal anomalies. Yeah, in the presence of Y gene, as what Dr. Shikin illustrated case yesterday, Sawyer syndrome, 46XY, phenotypically female, so gonadal dysgenesis. Yeah. So, in the presence of a Y gene, there is an elevated risk of developing gonadal dysplasia in a range of about 45%. Hence, you usually will advise the patient to go for gonadectomy. Okay. Now, fragile X, yeah. So, fragile X syndrome is an X-linked inheritance caused by mutation on the FMRY gene. Yeah. So the full mutation, that means you have a division of DNA of more than 200 transcript, will result in mental retardation, usually in the man who carry the mutation, because it's X-linked. Yeah? So if it's X-linked, the male will definitely be affected, and male usually will present with mental retardation. In carrier woman, when the CGG repeats is about in the range of 55 to 200, so they have an increased risk of 13 to 20% of developing premature ovarian insufficiency. Meaning to say that if you have a fragile X, not necessarily 100% you will present with premature ovarian insufficiency. So the chance is probably around 13 to 26%. So fragile X testing is indicated in all women with premature ovarian insufficiency after careful counselling. This is important because you have to counsel patient on the risk of transmission to offspring and also to the siblings itself. Yeah. Okay, so it's X-linked inheritance. Okay, if the female is a carrier, the chance a male baby, a male son, is going to be affected, and usually they present with Fragile X mental retardation. Female can be a carrier. In about 20% of them, they will manifest as premature ovarian insufficiency. Now, autoimmune, POI is more frequent in women with autoimmune. 4 to 5% of women with premature ovarian insufficiency will have the ovarian autoantibodies, and it causes selective destruction of the TK cells. So in patients with POI, screening for adrenocorticoid antibody should be done, and if it's positive, we have to refer the patient to the endocrinologist. So in my experience, because usually when we talk to the patients, they are a bit reluctant to do it outside because they have to pay for the amount. That's quite an amount. So usually we don't get cases that is detected positive. So, but POI is also associated with thyroid autoimmunity. When we send thyroid peroxidase autoantibodies, occasionally they are positive, and this patient should be combined managed with our endocrinologist. Okay. I'll illustrate a few cases so that we can get a better idea of how to manage cases with premature ovarian insufficiency. Case 1 is a 26-year-old Malay lady who was referred by a GP for primary infertility. She had secondary amenorrhea for 1 year. That means at the age of 25, she doesn't have any more menses, preceded by irregular menses for about 1 to 2 years before that. So she has a history of acute lymphocytic leukemia at the age of 18 and was treated with chemotherapy, and claimed she had completed treatment and was well. Subsequent to completion of chemotherapy, she had regular menses. Examination shows a small uterus, and both ovaries were not visualized. The hormonal profiles that were sent reveal a very high FSH, 125, high LH, low estradiol. Thyroid function and prolactin was normal. So probably in her, she is iatrogenic chemo-induced premature ovarian insufficiency. So in this patient, we have to counsel because she come for fertility treatment. So we have to counsel the patient on the fertility option that is available. And we know that because she's premature ovarian insufficiency, again, we have to counsel on starting on hormone replacement therapy that she's devoid from. The second case, 17 years old, who was referred for primary amenorrhea. She also has absence of secondary sexual characteristic with tender breast stage 1. No other significant history. Examination shows short stature 141, white space nipple, web neck, cubitus valgus, or both elbow. Diagnosis? Turner syndrome. So ultrasounds show an infantile uterus, high FSH, LH. We sent karyotyping in this patient. It came back as 45 XO. So in this patient, where the breast development is not yet there, so in managing this patient, of course, we have to induce her puberty. But she stood at 141 centimeter. So we also have to tackle on the height management. Next case, interesting case, the 27-year-old Malay lady who came to seek treatment for primary infertility. She had menarche at the age of 14, regular menses till the age of 18, then oligoamenorrhea, and subsequently past 2 years has been amenorrheic. She had no medical illness and no surgery. She had a twin sister who also had subfertility and also been amenorrheic for the past 1 year. No other siblings in their family. Her mother is a 48 years old and not yet attained menopause. So investigation that we done show a high FSH 45, LH 12, estradiol low, prolactin to SH was normal, and we sent for chromosomal analysis. Noted a break in one of the X chromosome. And we called the sister in. We also sent chromosome analysis for the sister, and we found similar findings in the sister. So what is important in this case to do a proper genetic counselling and to discuss what the fertility option that we can actually offer to the patient. Now, issues in premature ovarian insufficiencies are three main issues: the fertility, the femininity, and also the general well-being of the patient. So what is the option for premature ovarian insufficiency and fertility? So at the moment, there are no reliable interventions to increase ovarian activity and also conception rate. Premature ovarian insufficiency is not the same as poor ovarian reserve. In patients with poor ovarian reserve, they still have follicles And we can actually do something to actually stimulate the follicle, harvest the follicle with IVF and so on, and still they carries a chance of conceiving their genetically child. Yeah? But in premature ovarian insufficiency, the opportunity for fertility treatment and fertility preservation is actually missed. Yeah? So the option that we have for this patient is basically either to go for oocyte donation, adoption, or remain childless. Yeah? But of course, in oocyte donation, the issues regarding ethical and religious issue is something that we should actually discuss with the patient. So what do we do in oocyte donation cycles? We usually find a suitable donor, okay, stimulate the donor, and harvest the egg. At the same setting, we prepare the recipient, that means the premature ovarian insufficiency patient, with endometrial preparation, and synchronously transfer the embryo that we have generated from the donor with the endometrial, which are synchronous with the embryo age. So basically, this is what we do in donor cycles. Yeah. In KKM hospital, we're not allowed to do donor cycles. Yeah. Now there is in vitro activation. This is something which I think will probably give chance for patient who is having premature ovarian insufficiency. I will touch about IVA in my last slide. Okay. Now the second issues is puberty induction, as illustrated in case number 2. They don't have pubertal development, yeah, because they present with primary amenorrhea. When we say puberty induction, there are 2 organs that we want to induce, yeah, when reproductively. There is the breast and also the uterine development. In case we want to prepare the patient for subsequent pregnancy, the uterus need to be grown to a good size for the ability to hold the pregnancy, yeah. So puberty should be induced starting with a low dose, mimicking natural puberty. Yeah? In natural puberty, we take about 2 to 3 years for breast development before finally we attain the peak of puberty, which is menarche. So we should mimic the puberty. So how do we do that? We do a slow increase of estrogen. The one recommended is 17-beta estradiol, but we don't have over here the patch one. We don't have within our KKM hospital. So I tend to use the more natural one, which is actually estradiol valerate or Proginova, increased over the duration of 2 years, 0.5 milligram for 6 months, 1 milligram for 6 months, 1.5 for 6 months, and 2 milligram for 6 months. Now, and when to begin the progestogen? Yeah, you only begin progesterone when you see there is satisfactory breast development. For example, you see the breast still not developed fully well, you can actually extend your estrogen for up to 3 years, and you only give progesterone once you have satisfactory pubertal development, or the patient will tell you when they are ready to give progesterone, because sometimes with the estrogen itself they will start to have breakthrough bleeding, so you know that is the time that you can actually change to progesterone. Yeah. The oral contraceptive is contraindicated for puberty induction. You don't give OCP for puberty because OCP contains progesterone, and when you give progesterone, you will develop a not beautiful breast. You have a tubular breast instead of a good contour like breast. Yeah. Okay. Femininity. Dr. Nazima has talked a lot about HRT. So in patients who are premature ovarian insufficiency, they occasionally will present with all the symptoms of menopause. But in patients who have not primary amenorrhea, who have never experienced menses, usually they don't have the menopausal symptoms, because the hot flushes and so on is actually because of the estrogen withdrawal, actually, not because of estrogen deficiency. So this patient with primary amenorrhea, they basically does not have estrogen at all in the body, so they won't have any hot flushes symptoms. Yeah. So HRT have a role in prevention of cardiovascular disease and also bone protection. This is the summary of WHI study, which Dr. Nazima has beautifully illustrated. But in patients who are premature ovarian insufficiency, HRT has not been found to increase the risk of breast cancer and other risks associated with whatever has been found in WHI, because these ladies are supposed to be exposed to estrogen at that age. Yeah, so whatever that we are giving is actually much lower than whatever the body is actually producing. Yeah, So, but anyway, we see patient annually just to make sure they are compliant. The reason why we are seeing patients is actually to make sure they are compliant to our treatment, because sometimes dia tak larat dan nak makan, setiap hari nak makan kan, because they are still young kan. So we have to make sure that they are compliant to the HRT. No routine monitoring test is required. And when to do mammogram? She's only 20 years old, started HRT. Do you want to do mammogram? No need. You only do mammogram once a patient around the age of 45 to 50 years old. So in women with an intact uterus, you need to give progesterone supplementation 10 to 14 days in every cycles to reduce the risk of endometrial carcinoma. Okay. So general well-being, fertility, femininity, general well-being. Untreated premature ovarian insufficiency is associated with reduced life expectancy, largely due to cardiovascular disease. Yeah? So this is all the more reason to encourage and also to strengthen to our patient that actually you must take HRT. Yeah? So women with POI should be advised on how to reduce cardiovascular risk factors by not smoking, taking regular exercise, and also maintaining a healthy weight. Bone and POI, so estrogen deficiency results in increased bone remodeling with a net bone loss amounting to 2 to 3% per year. So women with POI have reduced BMD, which is assessed by DEXA, and it correlates with the duration and degree of estrogen deficiency. So it is important for them to continue the HRT with regards to make sure that their bone is taken care of. And do we need to measure BMD? Yes, at the initial diagnosis. But it's controversial when it presented with adolescent. Do we need to measure? Usually recommendation say no need. But if it's later in life, we still need to do a baseline BMD. And how frequent do we need to repeat the BMD? If the initial BMD is normal, it's sufficient to do every 5 years. Okay. So dietary supplementation in women with inadequate vitamin D and calcium, and majority of our Malaysian lady, although we are in the equator, exposed to sunlight, we are still inadequate in terms of calcium and vitamin D. So it is necessary to supplement this patient with vitamin D and also calcium intake. Okay. Now, can we give instead of HRT OCP? OCP produce a higher estrogen, so there's not advantageous. It's enough to give by HRT. And the second thing, in patients who have premature ovarian insufficiency, when their desire to get a child is still there, and you are giving so-called oral contraceptive pills, that actually contradicts with their wish for fertility. Okay, so they don't want to hear the word contraception. Okay. So CVS Health, HRT with early initiation is strongly recommended to control future risk of cardiovascular, and should be continued at least until the age of natural menopause, which is around 50 years old. Yeah. So you have to assess patient annually the cardiovascular risks such as BP, weight, and also smoking. Particularly in patients with Turner syndrome, where you start hormone replacement therapy. So you have to assess the cardiovascular risk factor, because Turner are at higher risk of high blood pressure, at higher risk of diabetic. Yeah, their chance of developing blood pressure is about 50%, and so are the chance of developing diabetes mellitus. So in a patient who have Turner syndrome, you have to actually assess them thoroughly in terms of blood pressure, fasting blood sugar, and also lipid profile, as they are at higher risk of cardiovascular events. Now, sexual and genitourinary health. So routinely inquire, although patient may not be forthcoming, but you should inquire about their sexual well-being. Are they okay with their sexual relationship? Are they okay with their libido? Yeah. So estrogen replacement therapy as starting point to normalize the sexual function, but in majority of patients, estrogen supplementation taken orally or by transdermal is actually not enough, because patients still complain of vaginal dryness and also dyspareunia, and occasionally we have to top up with the patient with a local estrogen. And local estrogen serves not only to treat dyspareunia but also improve the genitourinary symptoms. And occasionally premature ovarian insufficiency with problem of low libido, you have to probably they will benefit from short course of testosterone. but not too long, because you cannot give testosterone for too long. Okay. So can POI be prevented? Because you know the morbidity associated with premature ovarian insufficiency. So the next question, can we prevent POI? Yes, probably we can do something to prevent POI, especially in the iatrogenic one. So the modifiable factors include, probably you have to do a modified treatment regime for malignant and chronic disease. We use a more gonado-friendly regime, so that it doesn't have an effect on gonadotoxicity. And if the patients were to go for radiotherapy, it's good that if we can ovarian transpose the ovary, so that the ovary is out from the field of radiotherapy. And in doing gynecological surgical practice, always respect the ovary. If you do not need to remove the ovary, please keep the ovary. 35 years old, even if you think that the ovary looks okay, we try to retain the ovary as possible. The program of immunization by giving MMR probably will actually tackle the problem with mumps oophorytis and also reduce the prevalence of premature ovarian insufficiency associated with infection. And it is also important to identify those with family history of premature ovarian insufficiency, so that we can actually catch those who are at risk, and probably we can offer some programs such as embryo cryopreservation or oocyte cryopreservation, so that they can use in future. And also it is important to identify those with autoimmune disease. If, for example, in endocrine clinic, those who have autoimmune disease, please do ask also about their menses. If they start to have irregular menses, probably we want to assay their FSH, LH to see whether they are actually having declining function of the ovary. Okay, I just want to touch a bit about the cancer in the young. Okay, diagnosis of cancer in the young is actually a life crisis. Yeah. So in treating patients who have cancer and patients are young, you have to always balance between the oncology treatment and also the fertility preservation in this patient. So fertility preservation should be considered as early during treatment plan as possible, and oncologists should inform young patients about this option in comprehensive pattern with focus on medical and also ethical issues. Yeah. If you look at the American Society of Clinical Oncology recommendation, is that if a patient were to undergo a chemotherapy or any oncology treatment, so once have to assess the risk of infertility in this patient, and patients who are at risk for treatment-induced infertility should be referred, and interested in fertility preservation should be referred to expertise with fertility preservation. So we can actually preserve their fertility so that they can actually have their enhancement of fertility once they have completed their medical treatment. So the eligible proven fertility preservation method in male sperm cryopreservation has been there for many years, so we have adequate data to say that it is a very good technique. In female embryo cryopreservation also no problem, but there are still area of investigational fertility. For example, cryopreservation of the testicular or ovarian tissue, cryopreservation of oocytes, and also ovarian suppression during the period of giving chemotherapy. These are still experimental, but we have promising papers to suggest that this is actually an option for patients undergoing undergoing oncology treatment who still have desire for their fertility. So the established technique, as I've mentioned, embryo cryopreservation, ovarian transposition, you transpose the ovary out from the field of radiation, gonadal shielding. But area of research, for example, oocyte cryopreservation, ovarian, and also ovarian suppression. Okay. Now, before I end, I mentioned just now about usually they don't have chance of once they present to us with premature ovarian insufficiency, we always say that probably their chance of fertility is very, very low. But there are a few clinical papers, very interesting. Okay, what they do is that in patients who are established premature ovarian insufficiency by the definition, that means the FSH is high and so on. So what do they do in these studies? They take ovarian tissue, okay, examine the ovarian tissue under microscope, okay, and in some cases they do procedures to activate the ovarian tissues. They find areas which have follicles. That means gross the specimen and find areas which have follicogenesis still there. So, and then transplant it back into the areas of the ovary and areas of the ligament near the ovary. Okay, this is ovarian ligament, ovarian ligament, and also ovarian, the contralateral ovary. And there has been reported, Professor Suzuki and Kawamura is the two Japanese who has done a lot on in vitro activation. So they activate the follicles and they have live birth actually. So this is an area of research that I wish the younger generations, so I'm a bit older now, okay, the younger generation, Rizwan, Rose and so on, will probably go into, so that we can actually help our patient who has been diagnosed with premature ovarian insufficiency, so that they have their chance to actually father or mother their own genetically child. So this is a very interesting area, I think, that we probably would should venture into. Okay, so I come to an end. Before I end, today will be better than yesterday, because yesterday is over. We can't change or improve it anymore. However, we do have the power today to create, shape and influence the next hour, day and week. So start the day strong. So there are still a lot of areas that we can actually venture, so that we can actually help our patient to fulfill their desire of parenthood.